Welcome to a new edition of GYN Oncology Garage. I'm Ed Pavlik in Lexington, Kentucky.
And I'm Frank Lawson in London, United Kingdom.
Well, today we're going to look at a paper that was published in Radiology. Its title was Ovarian Cancer Detection in Average Risk Women. And it proposes a classic versus non-classic appearing adnexal lesion approach using ultrasound. Frank, you've read the paper. What do you think about it?
I've got a number of queries rather than comments on it. Obviously, like all things with ovarian cancer, it starts with a good number, 14,000 odd scans, whittled down to 800 and odd patients with adnexal lesions. The authors talk about average risk, but they don't define what average risk is. I'm assuming that these patients don't have a ovarian cancer family history. They don't have any genetic problems like BRCA1, BRCA2, no history of any other malignancies. So I'm just wondering where these patients came from. Why did they have a scan in the first place? Were they symptomatic? In which case, I can understand the figures, or was it more like they were completely asymptomatic, in which case this is ovarian cancer screening? And I think the detection means screening to some people, but it doesn't mean screening to others. I think that's the first thing. So why did the patients have a scan? Were they symptomatic? The other thing, it's interesting, the mean age of the patients is only 42. And if you're looking for ovarian cancer or worried about ovarian cancer, it seems a very young population. Also, the cutoff of the younger patients were had to be more than 17, which I think would miss a number of germ cell tumors. So I think the population in some way for this study is skewed, and I'm not quite sure why it's screwed in the way it is. The other thing is, of course, that they're only using ultrasound, and I think most studies of ovarian cancer detection would rely on ultrasound possibly in the first instance, and then tumor markers. And there's no talk about CA125 or germ cell markers, which surprises me to some extent. So they're relying on ultrasound alone. They try to determine the difference between what they describe as classical lesions and non-classical lesions. And I think most medical students would be able to say that a suspicious adnexal mass, it would be suspicious if it were had septations, cystic and solid, perforations, etc. So I'm not so sure that their classical and non-classical descriptions are actually true. I think that simple cysts, yeah, that's fine, but they're looking at more complex things than that. The results, again, are bewildering. The numbers are all over the place, and I really can't understand a lot of them. I know they're trying to dig down and find out what they can actually say, but the numbers, this, that, and the other, I find it very, very confusing. And the last thing is that the positive predictive value of 17%, and the authors do admit this in the discussion, is very much at the lower end of PPVs in other studies. The big study, UK Tox, Ian Jacobs and Usha Menon, they found 30-odd%, I think, was their positive predictive value. And it's 17%. That's going to mean if these patients end up having surgery, then 4 out of 5 of them do not have ovarian cancer. And I'm not so sure that this actually could run on something like that. I don't think that a PPV of 17% is compatible with a study that is worthwhile. And I think in the end, the other thing they say is that there's a difference between practices, real-time ultrasound carried out by a radiologist or a gynecological oncologist, rather than what seems to be here, in which case a sonographer has done the scan and then the pictures are being reviewed at a later date. So although I think the study is interesting, there's a lot I don't understand, and I think there's a lot of gaps in it, and I'm not sure that it really pushes forward our understanding or our knowledge of what we should be doing to detect the nature of adnexal masses.
I agree with you, Frank. Let me put up a summary of one of the things that you said, and we'll take it from there. The specificity problem that you mentioned places it lower than our screening study in the United States. the Kentucky study or the
Yep.
UKC tox.
Yeah.
And that's a result of inferior performance in terms of false positives.
Yeah.
And that of course drives the positive predictive value down. So if you take 15 to 17% as your positive predictive value, that means you're probably going to take 5 people to surgery who don't need it for every malignancy.
Yeah.
So,
Absolutely.
that's an important thing to pick up on. I would also say that the age distribution is for premenopausal versus postmenopausal. 75% of them were premenopausal. And you have to start to say that there's some discordance with what we expect for age distribution of ovarian cancers. So maybe they set the demarking line rather than at 50 or 51 lower or something like that, or they were too reliant on self-reporting of premenopausal, postmenopausal. But
Yeah.
that is sort of strange. All of these people probably ended up in the study because they are symptomatic for some reason.
Yes.
They certainly didn't walk into a screening study where all comers are taken, hoping to find people who have a silent ovarian
Yeah.
cancer.
Yeah.
So I mean, those are things that I think need concentration on. And in the end, when you start with these 14,000 plus cases, and you exclude what you exclude in their diagram, you end up with 970 cases to pursue. But then that gets filtered down to 53 malignancies.
Yes.
And so, you're dealing with a decreasing number type of analysis. That doesn't mean it can't be used, but it also means that one of the statements they make that they saw a difference, but it was not statistically significant. I think that was relative to age and menopausal status. I mean, it looked good numerically, but statistically, it was not
Yes.
living up to the cutoff.
Yeah.
So in the end, I think, that's where everything stands. We're in agreement. I sort of felt bad about the end of their conclusions in the discussion. And they recommended or were saying that the classical lesions should be referred on to MRI, which being a radiology profession here, that makes terrible sense. And then they were willing to refer the non-classical lesions that had color blood flow onto GYN oncologists for further evaluation.
Yeah.
For someone who's reading the paper, I think the last table is probably the most meaningful, and I'll get it up here in a second. And that's that really they do a Cox regression, well, the equivalent of a Cox regression. They do a Poisson regression on it, and they come out with what the bottom line is, and that's table 4, and that's up right now. I think I can have it up right there. So what you can see here is that they find a non-statistical factor being age, and a statistical factor being solid components and blood flow, and then lesion size. This takes us to where we were before the paper was published.
Yes.
And that's what everybody knows, whether they're a radiologist, a GYN oncologist, or
Absolutely.
or whatever. So
Yes.
I don't think the paper does any harm, but I don't think it's pushing things forward very well.
No, I think that's a very good review of it. We knew this 15 years ago. Nothing has changed. I think that's right. Okay.
Very good. Well, that takes care of another one of these in GYN garages, and I'll look forward to seeing you again next month.
Absolutely.
You take care.
Okay. You take care, Ed.